Good afternoon, everyone, and welcome. I am Gabrielle Darville-Sanders, Strategic Director for the National HPV Vaccination Roundtable, and I will serve as one of two moderators for today's session. I'm also joined by Christina Turpin, who will be my co-moderator and will be facilitating the Q&A session of our webinar titled HPV Cancer Prevention and Innovation. So in observation of the 2024 HPV International Awareness Day, we look forward to highlighting HPV vaccination and discussing innovative approaches to cancer prevention. We're very excited about our lineup of speakers and the HPV-related cancers that they will focus on for today.
Before we begin, we want to address a few housekeeping items. Today's webinar will be recorded. The link to view the recording and a PDF of today's slides will be shared with all who have registered, and we will also put the recording link publicly in the future. If you have any questions during today's webinar or any questions for our presenters, please use the chat and Q&A feature. And to ensure there are no disruptions during the presentations, all participants have been muted by the host. To ensure we have sufficient time for Q&A at the very end, we will be sharing panelist bios in the chat. So before we get started, we would love to share a brief video for you. As part of IPVS's One Less Worry International campaign, this video highlights the stories of HPV cancer survivors globally and brings awareness to HPV vaccination as cancer prevention.
Okay, so it seems like we can't hear the audio. So what we'll do is we'll stop, restart, and try again. Okay, so as we troubleshoot our video, what we'll do is we'll move forward and revisit maybe towards the very end. Our first presenter, for sake of time, is Dr. Brian Boyce. He will present on the topic of HPV-related oropharyngeal cancers, insight and prevention through vaccination. Let's go ahead and welcome Dr. Boyce.
Perfect. Thank you for having me today. This is it's a great honor. I appreciate the opportunity to be able to discuss this important topic. Just waiting for the slides to pop up here, and then we'll get going. All right, perfect. So like Dr. Gabrielle Darville-Sanders, is Brian Boyce, and I will be discussing HPV-related oropharyngeal cancer. Again, it's a great privilege to be with such esteemed colleagues. I'm presenting on various HPV topics, so I just appreciate the opportunity. Next slide. I have no disclosures. Next slide. So just starting from a very high level view to begin with, and then we'll work our way down to HPV oropharyngeal cancer. In the United States, there's about 14 million new cases per year of HPV infections, with about 70 million people at any given time having an infection. And so in the United States and in the world, the human papillomavirus is the most common sexually transmitted infection. And almost all adults who are sexually active will become infected with this virus at one point in time. So you might be aware that HPV causes warts, both of the anogenital area and of the skin. And you might also be aware that it causes wart-like lesions in the upper respiratory tract called recurrent respiratory papillomatosis. And a lot of people are aware that it causes cancer, but usually when they think of that, they're thinking of cervical cancer. And so next slide. So in fact, HPV is the cause of 6 different types of cancers. And each year in the United States, about 37,000 people will be diagnosed with a cancer caused by this virus. And these cancers include cancers of the cervix, oropharynx, penile cancers, vulvar cancers, anal cancers, and vaginal cancers. One thing that a lot of people also don't know is that starting in about the early 2010s is that cervical cancer is no longer the most common cancer caused by HPV in the United States and most Western nations. And now oropharyngeal cancer is the most common HPV cancer in the US, with about 20,000 cancers of the oropharynx being diagnosed each year, compared to 12,000 HPV-associated cancers of the cervix. And so, what is causing this epidemic of HPV-linked oropharyngeal cancer? And so, beginning in about the 1970s and 80s, we were starting to see a dramatic rise in the rates of oropharyngeal cancer. And you can see that reflected in the graph on the right-hand side of the screen. And when researchers began looking at it, what was causing this dramatic increase, they determined that it was caused almost exclusively due to HPV infections. When they tested cancers from the 1970s and 80s, there was consistently about a 15% rate of cancers that were being caused by HPV. But now, when we look at it, almost 80 to 90% of these cancers are caused by human papillomavirus, meaning that 8 to 9 out of 10 patients who are diagnosed with this cancer will have the cause be due to a viral infection. Next slide. So interestingly enough, over the same period of time where most other head and neck cancers are decreasing in incidence, which we can see on the chart on the left, where oral cavity and laryngeal cancers, larynx cancers or cancers of the voice box, are going down, you see a dramatic rise in oropharyngeal cancer. The decrease for the other cancers has been due to the very successful efforts to reduce smoking and alcohol use in the general US population. And so when we see a dramatic rise, it has to be attributed to something else. And so the graph on the right, we see the yellow solid line is the rate of increase in new HPV oropharyngeal cancer diagnoses. And then the dotted blue line underneath that reflects that this is almost a disease exclusively seen in men. Also on that graph on the right-hand side, you see over the same time period, cervical cancer rates are going down, which is what we want. This is due to increased efforts with screening, increased access to screening, and improvements in HPV vaccination rates. Next slide. So before going any further, it would be helpful to define what the oropharynx actually is. A lot of the times it is confused with the oral cavity, and you'll see a lot of things discussing the oral cavity and HPV, but this disease is a disease of the oropharynx. And so on the picture on the left, you see that the oropharynx is that teal area. It's the part of the throat behind the mouth. And in the oropharynx, there's an abundance of this lymphoid tissue, which you see on the picture on the right. This is what we commonly think of as the tonsils. Those are, to physicians, called palatine tonsils. And that same lymphatic tissue continues in a U-shaped kind of form along the base of the tongue. And that's what's called the lingual tonsils. And this tonsillar tissue, this lymphatic tissue, is very important for training and building the immune system when you're young. And it's also a first line of defense for viruses and bacteria that pass through the mouth. And so while you will see some cancers of the oral cavity or maybe of the larynx or voice box that do test positive for HPV viral DNA, these are very rare. It's most commonly a cancer that is linked to the oropharynx, to the tonsils, and to the base of tongue. Next slide. So why do we see a dramatic rise in HPV-associated oropharyngeal cancer? It is mostly due to changes in sexual practice over age cohorts. And what we see is that it's really linked to the sexual revolution of the 1960s and 70s. So when you look at younger age cohorts, you will see that they are more likely to have an increased number of oral sexual partners, a younger age at sexual debut or when they first have their sexual experience, and just an increased number of sexual partners overall. And in the graph at the bottom, you will see that there is a direct linear relationship with the number of oral sexual partners and sexual partners overall, and an increased risk of acquiring an HPV infection. Interestingly enough, we know from earlier that this is primarily a cancer that we see in men, and and sexual practices only account for a very small percentage of the difference between men and women, meaning that there are some other factors at play besides sexual practices. Next slide. So oral HPV infections are found in about 7% of the US population. And there are about 2 million or so people in the United States at any given time with a high risk type of HPV infection. And there are over 200 different types of HPV. Most of them do not cause cancer, only a small handful of them do. And so why does it infect the tonsil areas in particular? And that is due to some of the anatomy that is specific to the lymphatic tissue here that allows the virus to enter into some of the tissues underneath the lining of the throat, and it allows it to infect and evade the immune system in these areas. It's important to note that the infection in the vast majority of people is going to be cleared by the immune system. Just means that it's eliminated completely. So greater than 99% of the time, these infections will not be persistent and will not lead to cancer. So it's a small percentage of people who will develop a high risk infection. It's a small percentage of people who will not clear and move on to a cancer of this area. So we're talking about a very small subset of the population here. So next slide. So along with differences in the root cause of why these cancers are developed, there's also differences among the demographics, the clinical presentation, and the prognosis of these cancers. HPV positive cancers are typically seen in Caucasian males. It's very common to have patients in the higher echelons of the socioeconomic classes. And it's very, very common that these patients will not have any or very little tobacco use or smoking history, and none or very little alcohol use as well. The one common theme is that they have a high number of sexual partners, and usually the cutoff when we look at the number is around 5. Whereas in HPV negative cancers that are not caused by the virus, these are more equally distributed across sexes and ethnicities, and they are more tied to high alcohol use, high tobacco use, and are seen in the lower and mid socioeconomic classes. The clinical presentation is completely different as well. HPV positive patients have almost no symptoms other than a neck mass where the cancer has spread to a lymph node in the neck and has slowly grown over time. Whereas HPV negative patients will have a lot of symptoms related to the primary tumor, difficulty swallowing, throat pain, difficulty, a lump in the throat, ear pain, or painful swallowing. The one silver lining to this epidemic is that the HPV positive cancer patients have a much better prognosis in the treatment of their cancer. They have about a 30% reduced risk of dying and about a 50% reduced risk of recurrence compared to HPV negative cancer patients. Next slide. So now that we've gone into some of those details, we'll go into a little bit, just a very, very quick slide about the treatment options. So treatment for this cancer, there's no way to sugarcoat it, it's just very rough. The main standard treatment is with 7 weeks of radiation and 6 weeks of chemotherapy. And it's just a tough treatment course. You have to go to the radiation treatment facility 5 days a week. Each patient, as you can see in this picture on the bottom right, will have a custom-made mask for the patient. And what that mask is used for is that they essentially bolt you down to the table so you can't move during the treatment. And it's important for the treatment. You want to make sure that what they're aiming for is what they are hitting with the radiation beams. But this obviously causes a lot of anxiety and a lot of fear for patients when they're undergoing this process. The other main option that's a little bit newer is robotic surgery or using lasers through the mouth to move the tumor. So the picture right hand of the screen is us using the robot to remove the cancer from the base of the tongue. And then at the same time at the surgery, an incision is made along the neck where we will remove the lymph nodes. These treatments are rough, like I said. They have lots of potential complications. So if there's anything we can do to avoid this altogether, that is in everyone's best interest. And then we do get a lot of questions about immunotherapy, where we basically harness the immune system to attack the cancer. But this is not quite ready for prime time. I do feel like in the coming years, this will be an integral part of the treatment moving forward. Next slide. So in addition to these short-term side treatment, there are long-term complications from the treatment that don't rear their head until several years or even a decade or so after the treatment. These can include profound difficulties feeding, aspiration, which is where food and liquids that you swallow go into the windpipe, and the patient does not even know it, in what's called silent aspiration. That's what we see in the picture on the right, with the contrast going down the food pipe and the windpipe. There's also chemotherapy-related side effects, chronic pain and fatigue, and then also radiation-induced bone necrosis, which is basically a dead jawbone, which is what we see in the middle picture here. Next slide. So how do we screen for these cancers? Unfortunately, there is no effective way to screen for HPV-associated oropharyngeal cancers. There's no test analogous to a pap smear like we have in cervical cancer. And even if we did have that test, there has never been a precancerous lesion identified in oropharyngeal cancer that can be targeted. For several years, oral rinses were popular, and you might have seen these advertised at your dentist office. That's where a lot of them were performed. But these are no longer recommended. The American Dental Association has officially made a statement that they don't recommend using these. And the reason why is that they just aren't cost effective. Even if you screen positive for it, there's no strategy to move forward with knowing what to do, especially knowing that 99% of patients will defeat will defeat the virus on their own anyway. One area that I do think is important is the what's known as the liquid biopsy. And in this graph here, what the researchers have done is they took patients who have been diagnosed with oropharyngeal cancer, and they looked in their blood for fragments of the viral DNA. And they were able to detect this cancer 100% of the time in patients within 4 years. And sometimes they were even able to detect it 7 to 11 years before they developed clinical manifestations. So again, not ready for prime time, but as this technology becomes cheaper to use and we develop strategies with how to use it, I think we'll see it. In the meantime, as with anything, primary prevention is best, and so that's where we come to vaccination. Next slide. So as we talked at the beginning, HPV vaccination is cancer prevention. The only available HPV vaccine in the United States currently is Gardasil 9, and this does cover the vast majority of the viral types that cause cancer. And so it is very effective. It has been shown that it produces neutralizing antibodies in the blood and for oropharyngeal cancer in the saliva. It has a long durability of immunity. It's still a relatively new vaccine, even though it's about 20 years old, or actually it's over 20 years old, and will last a long time. No boosters have been needed to this point. It's effective around 90% in preventing HPV and oral infections, which again, you can't develop oropharyngeal cancer without getting an oral infection first. So the graphs on the right are just kind of where we are in the United States with our HPV up-to-date vaccinations. Boys are still a little bit lagging behind girls, but we are catching up in that regard. But both boys and girls are far behind where we want to be at 80%. And a lot of this is just due to some of the inertia with how the vaccine was rolled out initially for girls and for cervical cancer. But now we really need to make that push that boys need to be vaccinated as well, since the #1 HPV-associated cancer is predominantly in men. Next slide. So how can we help? So really education and raising awareness among the population, both patients, both parents, both providers, is going to be key. In this one study, it showed that only 12% of parents and patients knew about HPV cancer of the oropharynx, and only 12% thought that the HPV vaccine was effective at preventing it. We really need to do better as physicians and providers at being a reliable source for information regarding this vaccine and this disease. It's been shown that when patients get information from family members, from social media, off various websites, that they're 4 times more likely to have misinformation. But we can do better as providers too. We have a wide range of understanding of this vaccine, how it works, what cancers it prevents. And so that range is from 22 to 100%. But at the bottom left, we can show that, or we have shown that education does make a difference. So in this one study, they had a webinar for pediatric clinics that talked about HPV and the oropharynx and how to give strong vaccine recommendations. And 97% of the practices were changed to include the vaccine, and they increased vaccine administration by 123%. And then just quickly on the right, we need to work at multiple different levels: system level changes, physician changes, provider changes, and then just educating and raising awareness among patient and parents. Next slide. So I was asked just to give a little bit. I'm the co-chair of the HPV cancer-free work group in Georgia, and we have an amazing group with amazing contributors. And so we have been able to do quite a bit, I feel like. We have got a broad coalition. We have partnered with the Georgia Pharmacy Association to help promote and ultimately pass in Georgia that allowed pharmacists and pharmacy techs to administer HPV vaccines. We have targeted pharmacists and pharmacy techs in our webinars. We've partnered with the Georgia Dental Association for webinars to raise awareness. And then we have wonderful pediatricians, family medicine doctors who are really pros and experts on how to get vaccines in arms. What are the scripts that are successful? How do we give strong recommendations? How do we get these vaccines started at age 9? And one of the things I'm really proud of, which was done by one of our partners at the ACS, is to work with CareSource. This is one of the largest Medicaid providers in the United States and in Georgia. We created this letter. You can kind of see it off to the top right of your screen that gave information about where we are in Georgia, what cancers the vaccine protects against, how we can do better. And this was mailed to over 40,000 parents and beneficiaries, and over 3,000 providers. And then also just remember the legislative efforts that we can do as well too. There's currently a bill in Congress, National Congress, the HPV Cancer Prevention Act, to raise awareness and funding for this. And then also some local work that we can do as well. Next slide. So again, here's some of the things that we can remember from the slides: that it is the #1 cancer caused by the HPV virus in the United States. It's clinically distinct and most commonly found in men. We need to do better with our HPV vaccination in boys and girls, and remember that it is cancer prevention. So just get involved, educate, and collaborate with stakeholders around where you are to increase HPV awareness. So that's all that I got. Thank you so much.
Thank you, Brian. We always appreciate the opportunity to learn more from you. I had a pleasure of working with Brian with the Georgia Work Group, so it's always a good time to connect with him and learn more about his area. So now we'll have Dottie, our presenter, our second presenter for today, Dr. Dottie Wiley. She'll present on the Punch Bowl: what you thought you knew about anal cancer and how HPV vaccination will shape the future of the next generation. So let's go ahead and welcome Dr. Wiley.
Good morning. I really want to thank the American Cancer Society for hosting this event. It's really important to get the word out, and we'll talk more about the Punch Bowl in a few minutes. Next slide. So, and could you advance it? And so I want to wish you a happy International HPV Awareness Day. Next slide. And I come from UCLA, and we welcome you as well. Please come visit us. We're a public university, and we serve the people of California. Next slide. So this is what I spend most of my day thinking about. It's a rather messy head, full of all sorts of things related to HPV. I've been doing this work since 1996 as a postdoc, and I'm an epidemiologist as well as a nurse, and I'm a professor in the School of Nursing. Next slide. So one of the things that's really important to remember is that cervical cancer is really the repository of our knowledge about HPV and HPV cancers. But still, in this day and age, as much as in 2018, we were still seeing an equal number of any infections in both men and women. And in the United States, it comes to about 11.8 million, nearly 12 million cases per year. And when you look at disease association, about half that number, a bit more than half, and both males and females will develop some disease association. And I want to bring you back to that because it's not all cancer or precancers. HPV 6 and 11, which Dr. Boyce talked about in the last talk, those are low-risk viruses that cause genital warts. And I will tell you from vaccine studies that I did with Merck when I was involved as an investigator with their monovalent initial proof of principle study, and then with the 9-valent vaccine, is that what young people in my university often think about is they're thinking about genital warts, which stigmatize people. And they think of cancer as something that affects their grandmothers. So one of the things that we need to think about is why the vaccines were actually constructed the way they are, and we'll talk a bit more about it. The IARC is the International Agency for Research on Cancer, and they're located in Lyon, France, and they convene experts on a regular basis to talk about human carcinogens. So these group 1 HPVs are actually a group of 12 HPVs that are most often associated and show causal links to cancer. And so you'll see that 7 of the 12 viruses are included in the vaccine that's available in the United States. It prevents more than 90% of the cancers in the cervix, and it prevents even a larger fraction in the anus and other areas. And then HPV 6 and 11, you'll see down below, there's a relatively small fraction of the cases of new infections are from 6 and 11. But the reason that these viruses are really important is that if you're using cytology, which is also known in the public as a pap test, these particular viruses really mess up our ability to make decisions about referral for diagnostic follow-up, because they tend to give you low-grade dysplasias that show up on any cytology test. And the actual provider is faced with the fact that they can't ignore those because of liability. So we end up over-treating populations in order to prevent cancers. Go ahead. So HPV prevalence patterns, what you tend to see is that a fraction of these HPVs are linked to cancer, that HPV in the cervix is probably the largest repository. These group 1 carcinogens, HPV 16 and 18 is highlighted here because these are the 2 most pathogenic viruses. And then the other 10 viruses are listed. Group 2A and B, those are viruses that are actually considered probable possible causes of cancer. And the reason that the HPV 66 and 68 are highlighted here is because they are included in several of the screening tests that we use in women and that have been used off-label in other studies. We've used them in our studies as well. And it's one way to separate within the marketplace the differences between the viruses. Otherwise, they would just be copying one another's products. HPV is covered by Gardasil. You can see them highlighted here. HPV 6 and 11, again, in the Gardasil 9 is a low-risk virus. The other yellow viruses are the ones that are causing more than 90% of HPV cancers. Go ahead. So this is the way the virus works. This is the homeboy of all viruses. It really requires, a lot of my students, when I ask them this question, they think that if I took virus and painted it on my skin, I would suddenly get either a wart or some sort of a cancerous lesion. This virus depends upon microabrasions and trauma. And it needs to get way down to this other end of the underneath part of our skin. So I'm going to try and use my pointer. So can you see my pointer? Is that right, Gabby? I hope you can. So this orange layer down below is where the virus really wants to be. And so it infects those tissues. And then what you see in the pap test is this percolating up of these virus-infected cells. And so on the far left, you tend to see sort of a normal cross-section of tissue. As you move across to the right of this, what you're seeing is low-grade and high-grade dysplasias. And the little black dots that look like pepper, those are really new virus particles and so forth that are being shed into the environment. This dark area on your right is actually how a cancer would evolve. Again, this is a virus that hunkers down and stays put and just churns and churns and churns. And one of its mechanisms is to turn on the cell cycle, create more cells that are just duplicating, and they tend to develop sort of polymorphisms over time that accumulate. And every once in a while, you'll end up with a cell that actually mutates into a cancer. Next cell, next cell, next slide. This is the continuum. We see this in all tissues, is that you'll have normal epithelium here on the left. And epithelium is what's really lining those squamous cells that are lining our body surfaces and our all of our passages. And so when you have an incident infection, the virus takes hold, just like we showed you, and you will get HPV detection, and sometimes relatively quickly afterwards, especially with HPV 6 and 11. Most people will clear their infections within approximately 2 years. And if they clear, they revert to a normal epithelium. But some of them along the way will get these mild cytologic abnormalities we call low-grade squamous intraepithelial lesions, or LOCIL. And these LOCIL lesions, again, socially, they cause difficulty in our population because they're stigmatizing. But in addition, they sort of muck up our ability to screen well when we're looking for things like cervical cancer. Among those infections, there's a small fraction that actually, by the time most women, for example, have turned 30, the majority of infections that are acquired from the sexual debut through the 20s, they've cleared, but there's a small fraction that you're going to start seeing that are persistent infections, and they may progress in disease to form low-grade and high-grade, but here we're really concerned with high-grade neoplasias. So this high-grade disease, they could sit there for many years. We can detect them in cervical screening in the cervix, but a fraction of those go on to invade, and they develop into invasive cancers. Next slide. So this is just showing you the difference in what we know about the virus. The little red bars are showing you HPV infections in women who have normal cytology. Their pap tests are negative. They don't have any intraepithelial lesions, but we can detect the virus in those specimens. You'll notice in the United States, the prevalence is a bit higher. The purple bars are actually showing you that when we look in tumors, it's quite different. And so what you'll see in tumors, if you take cervical cancers, is about 72% in the North American continent are due to HPV 16. So what you'll see is this disparity between what you see in tumors versus in just normal cytology. It's really telling you why HPV 16 and 18 are special. Next slide. So put another way, this tells you what the distribution is of those HPVs in tumors. It's about 72% of them in the United States are related to HPV 16. Close to 7% of them are going to be related to HPV 18, and about 12% are going to be related to other high-risk HPVs. Next slide. I did want to bring one thing back to you because the testing environment that you may hear about, and again, as these tests are targeted and created for other kinds of cancers, so that's my dream, is that we're going to get one that's targeted to predict as well high-grade disease in anal cancers. What you're seeing now in the marketplace is because these adenocarcinomas behave differently. You'll see a larger fraction of them are going to be due to HPV 45, which is this purple bar on the right. You'll see it's a smaller fraction of the cervical squamous cell carcinomas. And so these adenocarcinomas are less frequent numerically. It's a smaller number of people, but they tend to be more difficult cancers to treat. Next slide. So detecting them is really important. This is a really busy slide. You'll have time to look at it when you receive the slides. The long and the short is that this is some work that Clifford's group did at IARC. And what they did by looking at a broad number of studies is, I just want to draw your eye that when you look in men and you look at HPV 16, whether people have HIV or not, right? And in women, HIV or not, it still remains sort of the number one batter up. Go ahead. This is a little easier to understand. So this is asking you the question about the prevalence ratio. So the ratio of the prevalence, which, for example, for 16, 86% in this international sample that they looked at, versus in normal cytology, about 18%. So it's about 5 times more likely to be found in tumors than in normal cytology. And in HIV infected folks, which is the not the darkened image, so the little white circles and bars, those are HIV infected folks. What you'll see is a little bit of variation, but some of that has to do with looking down this particular column in normal people, is that in HIV infected people, you'll tend to see a higher prevalence at baseline, meaning that they have more common difficulty with this virus than people that have immune competency, even when they're under treatment. Next. Next slide. Great. This is Clifford's work as well. It's one of those pictures that just keeps on giving. So what they developed was a risk scale, and this is anal cancer. And so if you look at 100 cases per 100,000 is this red spot. When you look at stratifying all of these different people who have risk factors for anal cancer, what you find is that HIV, by and large, really shines in its risk for people, especially over the age of 30, which is guiding a lot of the new recommendations on screening. So in HIV infected folks, they're recommending 35. Most of the professionals I work with, 35 and older. But there are other groups that I just want to draw your attention to that we need to think about. And I really do, for a social justice perspective, do want to draw your attention to it, is that while the rates in this group are very high relative to the rest of the cancer rates, more than 50% of the cases of anal cancer numerically are in women who have no known risk factors. So they don't fall into these high-risk groups. We do have other high-risk groups that people don't think as much about, which people that have solid organ transplants. And I can show you some information of why I draw your attention to this in the last slide that we'll talk about with our new work in vaccination research. But you can also find groups of women that are at higher risk, women with vulvar cancer or precancers historically. And so again, these are just really important indicators that this is, while this is an equal opportunity infection, there are other features that actually put people at risk for anal cancer. Next slide. So the punch bowl. So I often tell people this sort of funny story. It was an experience I started having in 1996. Most people, when I go to social occasions, don't know what I do. And I have laughingly told people over the years that when people ask me what I do, I would swear to you that they probably think I sell real estate. Not because real estate's a bad job, it's just not what I do. And when I tell them that I study anal cancer, they start backing away from the punch bowl, because people don't talk about the anus, number one. That's sort of not a topic of discussion. It's socially unwelcome. And when you tell them that you study a cancer, which is also something that makes people very uncomfortable, it just shuts down the conversation. So I've learned new and interesting ways to talk about what I do. I'm passionate about it. I've worked with a lot of very high-risk people over the years, and I'm deeply moved by what they work with. We are working right now on doing a large quality of life for survivorship with people with anal cancer, and we hope to come forward with more information about people that have long-term follow-up. Next slide. So the last thing I want to leave you with is that when we talk about cancers, anal cancer, whether we're talking about oropharyngeal cancer, anal cancer, penile cancer, any of these cancers, the morbidity that's associated with them, irrespective of what the mortality is, because again, with chemoradiation, which is what the primary treatment is for anal cancer, so you get full pelvic radiation, and it's targeted, but you also end up with mitomycin C and platinum drugs as well. There are a lot of side effects that people live with for many, many years. So one of the things we have is we have the ability to vaccinate and prevent these cancers. And so while I know we're struggling in our nation related to issues of vaccination and choice, the reality is that I have yet to meet a parent who really, number one, ever thinks of their child as being at risk for cancer. And the only parents I know that are different show up in these data that I'm going to talk with you about. But talking about cancer and trying to recenter this conversation away from sexuality onto cancer prevention is a really important strategy. So to lead you through this very quickly, this is some work that I've been doing with my colleagues. We started with 1.56 million children. This is through some work we've been doing with Optum Data Warehouse. And we've looked at 9 to 15-year-olds, and we've pulled out about 3.3% of these 1.5 million kids have 4 representative developmental disabilities. And we chose these based upon their representativeness of the kinds of problems that you might expect to see in a broad sort of array of developmental disabilities. And they include neurological, orthopedic, cognitive, as well as neuroatypical. So we've looked at cerebral palsy, intellectual disability, spina bifida, and autism. Our largest population is children with autism. The second largest is intellectual disability. Cerebral palsy is third, and the smallest group, which comprises close to 1,900 children out of this 1.56 million, are children with spina bifida. And so, Gabby, will you tell me, can you see? So I'm going to use my annotation.
Yes, we can see it.
Okay, I'm going to use my annotation and draw a few lines. So, and I'll trust you'll erase them for me. Okay, so let me make sure, there it is. Okay, so here we go. So what this data shows is that when I control for all the factors that are listed on the left side, these children that have cerebral palsy, at the end of the day, when I control for all of their chronic conditions that are underlying, the independent effect of the cerebral palsy, they're 6.5 times less likely to get an HPV vaccine between 9 and 15 than their otherwise unaffected, very similar kids. When we look at children that have intellectual disability, they're about 3 times less likely to get a vaccine than children that are unaffected. And for spina bifida and for autism, they're about 2 times less likely. Okay, we see that males to females, which Dr. Boyce mentioned in the last talk, males are less likely to get a vaccine. So that's this particular time point, and it's a fairly precise estimate. We see that if we control for the effect of provider visits, it's really important, because why I think it's important to mention to you is that we see children that have a wide array of provider visits. And that may be a child on average that's getting approximately, 6 to 7 visits in a 5-year period. And if you're depending upon the health system to completely manage this, as opposed to thinking about public health and other ways we can encourage people to get vaccinated, it's the most expensive way to go. So I really favor trying to come up with additional strategies that augment our healthcare providers and allow them to be able to do the things they need to do. What you also see across the period between these are kids that were born in 99, so we picked them up when they were eligible for vaccination at 9. And so this is starting in about 2006. And so each of those years with these different birth cohorts, so these are when they were born, each of those years it's improving over the first year that it was made available to females. The last thing to tell you about, and the reason that I brought it up earlier, is that the one group of parents that seemed to didn't surprise me is that parents of children that have a pre-existing malignancy, a childhood cancer, they're about 30% more likely than unaffected children to have their children vaccinated before they're 15. And so I think that that says something about how it resonates, that if parents see that they can take one thing off the table for a lifetime risk related to cancer, we can make that happen. However, what we also see, and I wonder, and I have some ideas about this, is that there are particular characteristics that I think reflect a little bit about bias. So if you have a transplant, a child with a transplant, they're about 2 times less likely to get a vaccination than children that have never received transplant. And technological dependencies can be everything from needing oxygen at home, having to be on a home monitor, having a gastrostomy tube. Those children are less likely. So my point is that trying to understand how chronic illness influences either providers or influences parents in the way that they participate in vaccination for HPV. I've had some conversation with parents over the years. I'm a really cheap date. People can call my office. I'm free. I can't tell them as a provider how to manage things, but I can answer their questions. And about a decade ago, I received a call during the middle of a day from a mom who had a child with Down syndrome. And this child was turning around 13 or 14 years of age. And the mom said to me that she was on a group chat and that all of the people on the group chat back then, a decade ago, were telling her, no, our children deal with too much. It's just too much. Why would you take a risk for a child that's not going to be sexually active? And so I listened to her and I talked with her. And one of the things that came out in our conversation was I said to her, so I understand what you're saying, but if your daughter doesn't necessarily, she might choose to be sexual and she might not. And the answer is, if she acquires an HPV infection, how will that be for her to be able to manage all of the diagnostic, the screening follow-ups, all of those things that would come with that, and relative to getting, at that time, 3 injections. And so I think that it's all how we frame the conversation about vaccinations to prevent these cancers. Anal cancer is the 3rd leading cause of HPV cancers. Nobody wants to be in first place, but we are 3rd. You're going to see, relatively speaking, about 12,000 cervical cancers. You're going to see close to 7,000 anal cancers every year diagnosed. And we anticipate that may go up a bit before it plateaus. So the long and the short is that when you look at our data and you're asking the question, in the most vulnerable of children, as far as being able to make decisions for themselves, they need the help of those around them. Oftentimes what we see is that they have a lower odds of vaccination. And so taking this home and taking it to the next level of being able to talk with families about how important it is and the kinds of questions that you would be answering for them is really important to me. Next slide. Hey, it erased. So I want to thank you. This is our inverted fountain at UCLA. We will welcome you to the campus. Please do consider visiting with us. Thank you.
Awesome. Thank you, Dottie. We appreciate that presentation, and we learned such a great deal about just the transition of cancer to anal cancer and now why we should vaccinate children with disabilities. And so I have the pleasure of introducing our final presenter, Dr. Curtis Pettaway, and he will present on the topic of penile cancer strategies for a preventable disease. Welcome, Dr. Pettaway.
Well, thanks, everyone. It is an honor to be a part of this. And I really, just listening today, really learned so much with respect to HPV. I'm going to talk a little bit today. Let me see if I can get my slides to go. There we go. About penile squamous carcinoma as a strategy for a preventable cancer. So I'll give you a little outline. We'll talk a little bit about clinical presentation, how we diagnose penile cancer, risk factors for penile cancer, which are both non-HPV related and HPV related. We'll talk a little bit about the natural history of the disease, very briefly about the concepts of how we treat it, and talk a little bit about HPV as a prognostic biomarker, and very similar comments to Dr. Boyce as well, and then some of the prevention strategies kind of along the continuum of penile cancer. All right, let me go back again. Okay. There we go. Get back here. Okay. So one thing about the anatomy of penile cancer, which you see here, this is the head of the penis that we call the glans. On the instruments is the foreskin, which if a man has not had a circumcision at some point in time, he does have a foreskin, which covers the head of the penis. And then that environment between the head of the penis and the foreskin, we call the preputial environment. And because this covers the head of the penis, this is kind of a closed environment. And when we think about many men who develop penile cancer and do have an existing foreskin, many of the cancers actually develop in this area. This slide over here, I hope the slide to the right, I hope you can see that. If you can see my arrow here, let me see if I can go to the annotate and get an arrow. There we go. There's my arrow. Okay, so this shows an ulcerated kind of fungating mass involving the head of the penis. This is a very typical presentation. These men often have these lesions months to years before presenting to a physician due to either embarrassment or shame. And it's unfortunate because the later the presentation, the more radical the treatment will need to be. And in fact, when you look at the location of most of these lesions, they occur very distally on the penis. And so that means that this should be amenable to early detection and diagnosis. If one showers, if one bathes, one does self-examination, these areas should be very easy to see, and therefore cancer should be easy, or lesions, pre-malignant or cancer should be easy to see. I'll go to the next slide. Let me see if I can get this. I'm going to go ahead and close that out. Okay, there we go. Now, Mike. Okay, so with respect to diagnosing penile cancer, often you see, just as you might see in the slides to the right, a lesion, reddened lesion, either on the skin of the shaft or a lesion on the head of the penis. And basically how we diagnose this is just often by physical exam. And we want to examine the penis, looking for site number, size of lesions, whether it's mobile or just involving the skin or involves the deeper structures. We also want to examine the inguinal region because men often may present with inguinal adenopathy or enlarged inguinal nodes, because penile cancer spreads from the penis to the inguinal nodes as the first site of spread. And so biopsy, of course, establishes the diagnosis. Just because you see something red on the penis doesn't mean it's cancer. Fungal infections, bacterial infections, sexually transmitted diseases are all things that can cause red lesions on the penis. So biopsy is what needs to happen to actually establish the diagnosis. And often in the clinic, when I see somebody whose lesion hasn't resolved over a specific period of time, I'll do what's called a little punch biopsy using one of the tools that you see on the right. Very easy way to establish a diagnosis and get depth. And these can be closed with a little suture right in the clinic, and you make a diagnosis without delay. With respect to imaging, imaging can be important from the standpoint of view of examining the penis and especially the inguinal lymph nodes or ruling out distant disease. And we will often use CT or MRI. And then more recently, especially in men with advanced disease, PET-CT scanning is becoming certainly something that is of value because it tends to pick up disease that is occult. In other words, disease that you might not pick up on a CT scan might be picked up by the tracer used in the PET-CT scan. So from the standpoint of view of how common is penile cancer, well, in developed countries, it's rare. Less than 1% of cancers in men. If you look at numbers, it would be less than 1 per 100,000 men. So approximately about 2,000, 2,100 new cases and about 400 deaths. So of the cases, about, what's that? About 20% of those men will die of the disease. And so penile cancer can be a lethal disease and can be certainly expensive to treat, especially in the first 2 years. Now, in areas that are underdeveloped, this disease can really be a scourge. In certain areas of Africa, Asia, and South America, 10 to 20% of all malignancies in men can be penile cancer. So if you look at a place like in certain areas of Brazil, and you look at the incidence there, if we talk about in the United States it being, let's say, 1 per 100,000, and then you see rates here that are 3 to 6-fold higher. So penile cancer can certainly be a very devastating disease. And in underdeveloped or third world countries, the incidence of mortality can be very, very significant. Who gets penile cancer? Usually the disease develops in men in their 60s. That's where the incidence tends to peak. And that can certainly be unfortunate because when you're talking about treating the penis and one of the major treatments being surgery, that's occurring at an age when men are still very sexually active. So the morbidity of treatment can be very high. With respect to race and ethnicity, the incidence is similar among Caucasians and African-American men, again, less than 1 per 100,000, but higher in Hispanic men, Hispanic ethnicity. The incidence of mortality are 2-fold higher, especially in Puerto Rican Hispanic men. What are some of the risk factors for the development of penile cancer? One of the biggest, strongest risk factors is lack of neonatal circumcision. What is it about that preputial environment? Well, when you have a scenario where that environment is, when you get the actual phimosis, and what that is, really is it's repeated bouts of inflammation that lead to scarring of the foreskin so it doesn't move back and forth over the head of the penis like it was designed to do. So it becomes a closed environment. And what we find is that that increases the risk 7 to 10-fold. And in fact, in men who've undergone circumcision for the indication of phimosis, about 1/3 of them are found to have atypia. So this closed preputial environment really predisposes to the development of carcinoma. One of the things about circumcision, it not only decreases the incidence of penile cancer, but it also decreases the incidence of human papillomavirus and HPV. So circumcision can certainly be valuable. What are other factors? When you think of penile cancer, think of a cancer that's associated with inflammation as a major root cause. And the question is, okay, well, what is the source of the inflammation that can cause penile cancer? And that really will lead you to risk factors. Obesity is another risk factor. One study showed that as BMI increased every 5 units, the risk of penile cancer went up by about 50%. And so often men who are morbidly obese have a buried penis, a penis that they can't see. It's really locked away in the prepubic fat. So it, in essence, becomes a functional phimosis. It becomes an inflammatory environment. And again, atypia develops and it becomes a progressive thing, and they eventually develop a cancer. Other types of inflammation also are associated with penile cancer, such as penile tear, penile injury, chronic rash. And I'll highlight one form of chronic rash that we call lichen sclerosis. This is kind of a fibrotic, inflammatory condition involving the penis and the urethra. And these men are at very high risk for developing penile cancer over time. Over an 18-year period, as many as 2 to 9% of these men will develop penile cancer. And this is a type of a risk factor that is not HPV associated. What about other risk factors? Tobacco products are an important risk factor for the development of penile cancer, as they are for lung cancer, bladder cancer, kidney cancer, and other cancers. And in fact, the risk goes up 3 to 4-fold. And it's not tobacco, it's not only smoking, it's exposure to any tobacco product, whether it be cigarettes, smoke, whether it be chewing, dipping, any of those are independently associated with penile cancer. As we heard about with respect to anal cancer, HIV also increases the risk of penile cancer 4 to 8-fold. We know that men with HIV are at higher risk for HPV infection. And is this the reason? Well, it could be, but it's also, we know these men have an altered immune system. And that certainly is important because in HIV-infected men with penile cancer, they have higher rates of progression and death. Now, when we look down further at HPV infection, these can often be manifested by genital warts. And genital warts can be associated with HPV in over 90% of cases. So very common that you see HPV in genital warts. Many of them are what we call low-risk genotypes, which are associated with benign warts. But high-risk genotypes, which we've heard about already, which are capable of causing viral transformation of the cell, are associated with about 50% of penile cancer. So penile cancer is a little different than surgical and oropharyngeal. Only about 50% are caused by HPV. The other 50% are caused by non-HPV mediated mechanisms. And when we look at the diagram on the right, we can see that we can now stratify them into HPV mediated and non-HPV mediated. The HPV mediated ones are mediated by the viral oncoproteins E6 and E7, which affect protein RB and protein P53. I don't want to go through this whole diagram, but the important thing to show you is that when we're trying to detect HPV-mediated infections, there's now an easy way to do this. You don't have to do complex DNA analyses. HPV infection with respect to the high risk types is associated with upregulation of the P16 protein, which can be easily detected now by immunohistochemistry. So wanted to highlight that. And then on the next slide, I'll show you why this is also important. As of 2022, the World Health Organization, the WHO, reclassified penile cancer based on the major pathogenic pathways of either them being HPV associated or HPV independent. And this refers to either pre-malignant lesions, such as penile intraepithelial neoplasia, what we used to call carcinoma in situ, or the frankly invasive carcinomas shown on the right side of the screen. And we stratify them into HPV associated or HPV independent, largely by the P16 immunohistochemistry test. So this is a very easy way to stratify patients' prognosis. And then we can also see that, that there are distinct histologic subtypes that are associated with HPV and distinct histologic subtypes that are not associated with HPV. And we'll move forward. Now, when we look at the natural history of penile cancer, it starts out as a primary lesion on the penis, as you can see here in the slide. And this is often treated by primary surgery, which would either be what we call a penile sparing approach or an amputative approach. If tumors are very small, they can be treated by a penile sparing approach. But again, because of the delay in diagnosis, many of the men present with advanced tumors and it requires an amputation. And this is really psychologically distressing, especially to younger men with penile cancer. Now, what will happen is tumor cells will then at some point in time break off from the primary tumor site and embolize to the regional nodes. And many times this embolization phenomena is silent. So it's not something that can be detected clinically, and you wouldn't actually even know it because we don't have sensitive tests to detect microscopic disease. When a lymph node becomes palpable, then one can basically diagnose it. Now, if the cancers are detected in this primary tumor stage or with early regional metastasis, they are curable with surgery, chemoradiation, chemotherapy and surgery, various combinations. But if the disease is not detected early, then patients begin to have uncontrolled regional progression and they can succumb to regional complications. And the mechanisms of death in this situation can be horrendous. Patients can bleed out from the tumors in the groin or die from septic complications. So regional complications can be a common cause of death for penile cancer. Now, with respect to prognostic capabilities, we're learning more about penile cancer, and we're mirroring what others, like Dr. Boyce, have talked about in head and neck cancer. Penile cancer, from a molecular standpoint of view, looks a lot like head and neck cancer when we look at common mutations that are found. This one study looked at a cohort of patients who were treated for penile cancer from multiple centers, and they asked, overall, is there any difference in prognosis between those that are HPV negative or HPV positive? And when they looked at the overall group, they didn't see any difference in survival. However, when they looked at only the advanced cohort, where patients were selected for radiation therapy, patients with advanced disease that were HPV positive and treated with radiotherapy had a much better survival than those who were treated with radiation therapy and who were HPV negative. So HPV certainly serves as a prognostic biomarker, but it also may serve as a predictive marker for response to certain types of treatments. And in our own experience, we have also shown at our own center that, let me see if I can get that slide. There we go. Let me get that slide to show. That when we looked at patients who had advanced disease and were basically stratified either by P16 or HPV, patients with HPV or P16 positive tumors did better than those with HPV negative tumors, whether we're talking about cancer specific or overall survival. So I want to conclude by echoing the comments of my colleagues. And what I'll talk about very briefly here are strategies that potentially could wipe out penile cancer, whether it's HPV mediated or non-HPV mediated. And when we look at penile cancer as a disease that basically is found in men in their 60s, things that we do early in life can break this cycle of initiation and promotion and the development of penile cancer. First of all, you can prevent the development of phimosis, either by circumcision. Circumcision has been found to have multiple benefits. It decreases the incidence of neonatal sepsis due to urinary tract infections. It also decreases the incidence of transmission of HPV and HIV. But for those who choose not to undergo circumcision, prevention of phimosis through routine hygiene, paying attention to the details of hygiene with respect to the penis is a strategy which, again, can break this chain. And then, of course, we talk about things that are behavioral things, certainly avoidance of tobacco products, and then HPV vaccination, which is shown with respect to at least genital warts or pre-malignant in situ lesions of the anal canal to be very effective. And so by extrapolation, one would hypothesize that if one were to increase vaccination rates among females and males, that one would decrease the incidence of penile cancer, or at least HPV mediated penile cancer, very dramatically. So I echo the comments of my colleagues with respect to supporting all of the efforts that will galvanize us as physicians, healthcare workers, our government, parents, against the HPV epidemic, and using HPV vaccination to really eradicate HPV-mediated disease. And I will stop right there. Thank you very much.
Thank you, Dr. Pettaway. And thank you to all of our panelists and attendees and our team, Dr. Gabby Darville-Sanders and Kiara Long. We know we've gone a little bit over, so thank you everyone for staying on for these incredibly insightful presentations. Today, we learned from Dr. Boyce that oropharyngeal cancers are the most common HPV-related cancer, and to get involved, educate, and collaborate. Dr. Wiley encouraged us to stay at the punch bowl and continue the conversations about HPV vaccination and anal cancer, including the need to recenter the conversation away from sexuality into cancer prevention. Dr. Pettaway educated us on the complexities and risk factors of penile cancer and encouraged early strategies to essentially wipe out penile cancers and break the cycle. We encourage you to reach out to our panelists individually following this event with additional questions. And before we end today, we're asking that you please take a moment to complete the evaluation at the end of our session. The link will be provided at the conclusion of the event. We hope you've learned a lot from the information provided today and that you find it useful for your work. We'll share the recording and materials post the call. And we thank you all for joining us today and have a wonderful day.